Thank you so much, Daryl. And I want to personally welcome my chairman, Chairman Keplin and Alice. I know you came here on short notice, but I think it's absolutely critical. And I wasn't here, Chairman, to hear your testimony, but some of the smallest landmass, but the largest population, and it creates real challenges. And I know you guys are doing everything that you can. I'm going to, recently at a hearing, something happened that doesn't happen very often, and that is John Tester lost his temper. And honestly, it doesn't happen very often. He's usually very measured in his questioning and very respectful. But there comes a point when if we don't start yelling really loud about what's happening, if we don't start telling the truth that you just told, Daryl, which is this isn't an entitlement. There's a treaty obligation here on health care. This is a different way of fulfilling this treaty obligation. And we need to get more people to figure out. I was looking your insurance rate. You still have almost 40% of your patients who don't have any insurance at all. And we'd love to see. I mean, what percentage? And I won't get into that because I want to turn it over to John. But think about this: what percentage of those folks actually would qualify for Medicaid funding if we could get them to make the application, or make the application much simpler? To me, that's the trick here. I think people are afraid of listing all that when you start talking about what's revealed on those applications. And I think a lot of tribal members who I talk to, I encourage to sign up for Medicaid, say, why should I sign up for Medicaid? I've got a treaty right. Why should I have to apply for this? And so we have to change how we look at Medicaid expansion in Indian country, because it is different, in my opinion. It is different. And Dr. Warren, who is at NDSU, is doing a great job trying to come up with some ideas. He talked to Mary Wakefield, was the deputy HHS secretary. Talked to her about those ideas. I'd love to continue to pursue those ideas. But our first challenge is not to take a step backwards. And by repealing the Affordable Care Act, we take a step backwards. And let me tell you, if you take a step backwards in a lot of the places where you're trying to provide health care, you fall off the cliff, right? You fall off the cliff. So you better be looking behind you before you take that step backwards. And so we've been fighting this fight forever. I think you're well familiar with Senator Dorgan, who really began to highlight the challenges in Indian health. But we've got to figure out how collectively we advocate for what was bargained for, which is a treaty right to health care. And if we don't do that, if we don't continue to insist that we get that equitable, fair treatment, we're going to be falling off the cliff. The other thing I want to say before I turn it over to John is I'm deeply concerned, not just about whether it's culturally sensitive, but that we are, in fact, adopting a model that deals with the challenges. We all know that chronic disease is rampant in Indian country, that it's exacerbated by addictions, it's exacerbated by diet and diabetes, and that we need to have a different model, a different look. But we need to have a cooperative administration that doesn't cut Indian health 6%. I mean, again, a step backwards off the cliff. And so I want to applaud the chairman or the vice chairman for having this roundtable. I hope that we can build from this, because you all spent your time coming here, that we can build from this a unified voice of how we advocate for health care as a foundational piece. It's so interesting to me. People say we need economic development, we need jobs. Guess what? That's true. We desperately need economic development and jobs, but we need a population that is healthy enough to work. And if we don't have that, if we don't look at all of this, we just silo these programs, we're going to fail. We are absolutely going to fail. And so thank you all for coming. Thank you for sharing your thoughts. I have some questions that we want to get on the record, but I'm going to turn it over to Senator Tester, who really is a very nice man unless he's questioning Indian health.
Thank you.
Can I just add to that? One of the great frustrations that I have is that Washington Post will do a big story about, the child welfare, and that will be, all the talk. Now we've had the Wall Street Journal do a whole series on Indian health. This is an old story. We've been dealing with this for a year and a half, actually. So this isn't a new story. This is an old story. But there's always this kind of surge of, oh my goodness, we need to deal with this, and then it dies down. And then you become again the asterisk, right? Yeah. You then we don't have sustained outrage, and we need sustained outrage to fix this problem. So I want to just echo what John said, which is we need now more than ever sustained advocacy. And we need people to understand what this program, what the expansion of Medicaid means, and what the additional needs are. And we need a surge of help if we're going to work to stop the cycle and save the next generation. So I'll just add my thoughts to that.
And
Can you explain to me what you see as the fix to that?
By allowing the tribes to be able to have the money to invest in, whether it's healthcare underneath a regular, outside
Would
provider.
the tribe buy plans on the exchanges?
We can buy plans on the exchanges for our people, almost like a health account. We have to be creative with that. Oftentimes, it's less expensive for us to get an HMO for a family and pay that premium for them versus having them come to an IHS clinic or come back to us, particularly. And we also have to make sure.
I see this as similar to what we do with the VA.
Yes,
And
very
so,
similar.
So it would be really interesting to think about this a little bit more.
And-
Because we have this problem in North Dakota. What percentage, Chairman Keplin, of the tribal members, enrolled members, don't live on the reservation?
Yeah, well, we have
Can you use your
33,000
mic,
members
Wayne?
enrolled, but we have around 15,000
Yeah.
that live on
About
the
half.
reservation, so over half.
Yep.
Yeah.
Yeah, and that's what it really, the tribes, like each one of the tribes represented here and across the country, we're our best advocates and we understand what our needs are the best. So by being able to fund what we need appropriately and allow the tribes to make those determinations without the restrictions of the state, without some of the restrictions of the Indian Health Services, being a self-governance tribe, that's what we do. And we're creative. We stretch a dollar like nobody else, as you all know. But we just really need to get into allowing the tribes to do that for us. And then just preserving the Indian-specific provisions that are embedded in any of these things, any of the healthcare the new programs or the new laws that might come out, and really help to work in that bipartisan way and making sure that Indian country is sitting at the table through these roundtables and other discussions, because it's critical that we have the input to help guide. And also, Senator Testa, as you mentioned, outside of this room, so many people don't know that it's not an entitlement, that it's an obligation and a responsibility. And it's not an unmet need, it's an unmet obligation that we have to work together to try to move forward. And I offer my time and assistance any way that I can be. Thank you.
that's the problem.
So my reason for asking this question is that I mean, we could ask, but I don't hold out a lot of hope that this is going to be administration-led, a major IHS. And so I'm looking to who could do that. Obviously, we're going to be very interested as members of this committee and as people who work, but I'm just wondering.
Well, one of the issues you raised the question, Mary Wakefield and Mary Smith and folks in the last administration were trying to solve some of the complex problems, whether it's Great Plains or elsewhere in Indian country. The problem is that we ran out of time in order for it to be properly vetted with all the tribes with regard to a number of components. One was, for example, just how their central office functions versus the regional office and the resources necessary to fix the problems.
Yeah, I think we want everyone. I'm actually available until 11:30. I don't think this room's going to be occupied, so we can go a little bit over time here. So, but we want everybody to actually kind of weigh in, and so good dialogue. We're all building on what everybody's saying, so that's very helpful.
Yes, Samuel Moose, National Health.
Bring
Board.
your mic close to your,
Samuel Moose, National Indian Health Board Treasurer. I know that the National Indian Health Board has a number of representatives from all the regions, so this actually has been a discussion that they've had, that they've pushed the recommendations forward. So they have weighed in on the issue and supported that there be some long-range reform with regards to the Indian Health Services, along with appropriations. As we were talking, one of the things I constantly sit back and think about with regards to the region that I also represent, the Bemidji area region or Great Lakes region, and in the work that I've done over the last 18 years with regards to managing a specific tribal healthcare program, and then having a lot of dialogue with regional tribal healthcare folks within the Bemidji area. One of the things we always look at, and what I see with regards to the Indian Health Services system, of course, when we look at the question of what needs to happen, full funding is definitely one of those things, giving tribes the resources. When I look at our budget specifically for one tribe within Minnesota, about a quarter of my budget is made up within the Indian Health Services compact that the tribe receives. Medicaid, of course, the billing, our tribes are billing Medicaid at about 60 to 67% of their billing are made up from Medicaid. So it's a big
60%?
60% to 67%. It's a big part of their portfolio, and like you heard from Great Plains region, that it exceeds at times what IHS provides us under contracting or compacting, under direct service or self-governance. The other 50% of the pot of money is something that we're reaching for all the time through soft money, grants, other ways of doing innovation within Indian country, trying to purchase services, sell services. I've been doing it for about 17 years, trying to put together a $20 million budget, and trying to find the other 10 million of that has been incredibly difficult. Not only to mention that IHS itself is a discretionary pot of funding. So it's been very difficult on Indian country, and especially on the Indian healthcare leadership within Indian country. I myself, every year, try to fill in the gaps, and it becomes very difficult. My leadership within my area, the practitioners who are underfunded, when we're trying to ration out care, when we're trying to identify whether we're going to try to work harder on suicide prevention, or we're going to try to provide mental health, or we're going to try to provide transportation services, at any given time, we can't do it all with the types of funding we have. So we have to cut areas, and it's very hard on leadership. And when we look at retention and recruitment, that's a very difficult thing to do with regards to the leadership who burns out because we can't do it.
It's hard enough to recruit, but then you add this stress of delivering services and not knowing whether you're going to open up the clinic tomorrow because you don't have enough money to open up the clinic tomorrow.
Or pay somebody's pension or...
Lincoln?
or thing.
Thank you. My voice carries.
Thank you.
I've told other senators I've been doing this for 37 years. And 50% funding just doesn't make it. We have to be aggressive at looking, and we were told to go out and get more funding from third-party billing and the M&M, Medicare, Medicaid. And our biggest fear is it's going away. The other thing is, as a tribal leader, and I think this applies to all of us, that we're only funded from year to year.
Yeah. Yep.
The VAA is funded 2 years. We can't plan ahead 2 years. And then when you start having cuts and everything, we have to react. And then we have this time to wait when we have to kick in to pay for the time that's where there's no funding, and then we don't get reimbursed. There's a lot of nooks and crannies to this whole thing. But under self-governance, we've come a long way. Yeah. Right now, we're trying to grow our own. I serve as the secretary for Alaska Pacific University. We want to train our own people, our community health aides, our dentists and nurses. And that's just in the beginning stage right now as we talk, but still keep the university available for our young people. These are innovative ways that we're looking at in Alaska. Hiring and recruitment is very, very difficult in Alaska. We sometimes get people to the village, and if you don't have the Kmarts or the Costcos or you don't have to go downtown or to the big shops, it's not for you. And some people will last 3 months, 3 days. It takes a special person to live in Alaska. Alaskan is the true meaning of unique. It's remote. And it's isolated. And the funding that we get, we hold on to as hard as we can. We fight for every nickel, penny, and dime we get. And that's why I'm sitting here today. I was in Detroit, flew up there to Seattle, and said, we need you back here. And I just get ready for your 4-hour time difference, and here I am trying to not to fall asleep.
I want to thank you for coming because your voice is unique. I do a lot of work with Lisa, and when I complain about remote rural areas in North Dakota, she tells me her stories, and I just can't imagine the difficulty of tribal leadership. Tribal leadership has delivering services in that remote environment. I want to make one point about the year-to-year funding. When you look at the exemption that Medicaid and Medicare had from sequestration, that didn't happen on Indian Health. And so sequestration, you know, we saw the reduction in commitment to Indian Health. We saw the reduction that didn't happen in providing resources to any other population. So once again, this funding stream and maintaining this funding stream is absolutely critical. Thank you. Chairman Keplin? Press the mic and pull the, there you go.
Here we go.
There you go. Thank you.
Thank you. Senator Heitkamp, next time, please let me know before 2 o'clock on Friday afternoon that I have to be down here and trying to get reservations. Plus, my wife is mad at me because we were going on vacation on Saturday morning. So packed
now I'm in the
camper and everything.
doghouse.
Now it's done.
Now I'm in the
But I'm
doghouse.
blaming you. At least I got somebody to
I
blame.
owe you one. I owe you one.
But
Chairman.
anyway, we're kind of reiterate what we've talked about before. We have, even though we are in North Dakota, we have problems with recruitment as well, trying to get people there. We are home growing a lot of our people, as I said before, with the help of the university. They've got an InMed program that a lot of our people go to. We also have a pharmacy program and some other programs, I'm not exactly sure, at the college that we're starting, which our young people go to also. So we are doing some things to try and get our own people involved in our medical facility. And we do have some local doctors at this point in time that are working in our facility. So we are doing some of those things. But trying to get people to come and to work there is very difficult. One of the things that you were aware of, and you are too, is that you can get one to come and work, whether it be one of the spouses, but what does the other one do and the kids do when the other person's at work? There's no social, like you said, the Walmarts and the Kmarts. We don't have those, so there's nothing really for let's say the husband is a doctor. There's nothing for the wife to do. Where does she go? What does she do during the day? She can't go get her nails done because there's nowhere to go to get that done. So it makes it difficult to try and keep people there. They're there for, like you said, a week, a month, a year, then they're gone, and you don't see them again. So that's why we have to try and get as many local people as we can to get them educated in the medical field. And for us, it's starting to work. But Medicaid dollars that we're using, we don't do it with that, but we're doing a lot of things that we've been unable to do before. Right now, we're starting to contract with Sanford out of Bismarck. We have a lot of areas in our hospital that we need specialists in. And so we're bringing them in. Rather than us taking our people and transporting them for 3 hours, and I've said this before, we're bringing the people in to do that. We're starting to do that. We're also starting a cancer infusion center, which Medicaid has allowed us to do that. We've got a dialysis center, which Medicaid has allowed us to do that. We couldn't do it otherwise. We could not do it. As I pointed out before, our IHS budget is around $24 million. Our Medicaid budget is $27 million. So we're able to do a lot more with Medicaid than we can with IHS. And we have 33,300 enrolled members, and around half of those are in our area that receive services. You also pointed out the situation where your people live off the reservation or are somewhere else where you can't provide services. We have a lot of that too. We have people that, I've got a sister that lives in Sioux Falls. I got one that lives in Fargo. If they get sick, they have to come home. And they can't because they can't receive services out there. So yes, those are some of the things that we run into also. Those are some of the areas that we need help in.
So, Chairman, I do have a question. Alice put together this great chart, which I've been asking for a long time. You still have almost 40% without any kind of third-party pay, right? So
Yep.
what can we do to get that number up higher? Because I would imagine a fair number of those people, Alice, actually qualify for Medicaid, but yet have not registered. And I'm assuming that we're going to be able to fight back all this horribleness that's happening here and then start working on how we can make the programs that we have right now work in Indian country. So how can we do a better job here?
Well, the thing for us, I think one of the things, I'll let you get to that, Alice, in a second, but a lot of people that come to the health service are saying, you know what, I'm not going to sign up for Medicaid because that's a treaty obligation.
Right.
They should be providing me that service. And unfortunately, that's the way some of them are. They're not, and it's my age, the older generation, I'll say. And I hate to put myself in that category, but it does happen. But anyway, those are some of the ideologies that some of these people have, is that they have an obligation to provide me a service. And I'm not going to give them the opportunity to bill my insurance or bill Medicaid. I'm not going to provide them the information. So that's one of the reasons. And I'll let Alice go ahead.
Outreach, I think that's the factor there. I know that they've done a lot of outreach, but I know Shelley Harris, our CEO at the Indian Health Facility there, said that they are going to be hiring a few more people to start doing that. So she recognizes that we need that.
One thing that I would be very interested in, and you can comment too, is how we can make the application process work better in Indian country. For exactly the reasons that we've been talking about here, which is that this is not an entitlement program. You're not in the same status as people who would otherwise have health care. And then getting to the Medicaid registration. So many times, and you know this, Chairman, thank you so much, Lincoln. You know this, Chairman, mom gets sick, the only place she can get health care, she takes the kids out of school in Fargo, drives up to Turtle Mountain, and then you've got kids out of school and you've got disruption. And so, this is a critical piece, making sure that we get members who qualify signed up so that you can do third-party billing on the reservation, but they also can access health care off the reservation, and Ashley will get to you. So, Sam, you got a point here?
Just a couple points I wanted to make. With regards to, I agree that outreach is critical. Within the state of Minnesota, the state had worked with tribes to create tribal navigators as a way of creating access points within the tribal system for people to get signed up. It's worked really well. Of course, we could definitely work on some sustainable plans with regards to how do you support those tribal navigators, because oftentimes tribal members feel more comfortable giving their information to a tribal member than they would a county or a state.
Better training of tribal navigators.
Correct.
Yeah.
So I think that's an incredible access point, or that creates a thing. With regards to recruitment and retention, of course, our area that we've utilized within that a lot of tribes utilize, of course, is placement. So if you could somehow continue, I know IHS has some limited resource with regards to loan repayment, and unfortunately, some of those are there's still a tax on those loan repayments. We would definitely advocate that tax be lifted. And then HRSA has been incredible for tribes of creating sites for loan repayment. I know that our tribe, the tribe that I'm from, the Mille Lacs Band of Ojibwe, has utilized a number of spots for our clinics to bring people in. Of course, there's a limited time with regards to those, and we do see a window of turnover there, but it does get people into those tribal sites, and it definitely helps Indian country.
Yeah. Mr. Chairman?
Senator Heitkamp, a couple of things. First of all, with Medicaid, we're getting a lot of people that live in the city, like Minneapolis, that live there for 30 years or longer. Those people are starting to come back because they don't have insurance. And they're bringing their kids and grandkids with them. And so we're getting that influx of people that need these services. And so we have to be able to provide that service. And sometimes with the limited IHS dollars that we have, we'd never be able to do that.
Right.
Never be able to do
Yeah,
it.
no, I mean, the Medicaid story in Indian country is the least told story of all of the potential damage that will be done by a straight up repeal of the Affordable Care Act. And so we that's why we're here, is to tell the story, but also to talk about not how do we fight today's fight. Let's make sure that when Tom and I are old and gray, Tom's a lot older than I am. Old and gray,
Like
that we actually have done something. We actually have created and that's why I think this idea that let's look systemic at an overhaul of Indian health and how that works. Daryl,
Another
Alice?
big issue we have with recruitment is housing.
Yep.
We have a lack of housing within our IHS facility and in the private sector as well. No one's building homes. It's hard to retain our employees because there's no place for them to live.
Part of this, I want to make the point, when Secretary Castro came to Turtle Mountain, everybody talks about Pine Ridge. What his staff said is what they saw in Turtle Mountain was worse than Pine Ridge. And so you don't create an atmosphere if you don't take care of the schools. I think Senator Tester said it best. You don't take care of the schools, you don't take care of the housing. That just adds to recruitment problems. And you want to build housing for middle class folks so that they can live and create and do what they want to do back home. And so that's why I'm saying we just can't silo all these problems all the time. We've got to look holistic at what we need to do. And please apologize to your wife for me, but this is a really important discussion. Daryl, you want to add to the dialogue here?
Here you go. For the Pueblo San Felipe, we have sort of like a hybrid program where our dental, our pharmacy, our behavioral health, we've gone 638, they're contracted. Our main healthcare medical clinic is still under IHS. And although we're moving in that direction in contracting the whole program, we have some challenges that we have to work through with IHS local and maybe regional, for instance, EHR and RPMS. In order to build upon a sustainable program, we need the ability to collect, through Medicaid and through private insurance and whatnot. And so there are those bureaucratic red tapes that we have to work through in order to move forward in that. And with recruitment, if you look at the state of New Mexico, a map of it, you see Santa Fe in northern New Mexico, Albuquerque in the central part of the state. We're like right in the middle. Mm-hmm. We're half an hour between the two cities, but we still have our challenges in recruiting personnel there. And including doctors, and what the fear is, and I probably can say this, is if the tribe were to move toward contracting, those IHS employees that are there right now, that are the commission corps and what have you, are kind of fearful because they fear, okay, well, if the tribe takes over this facility, are we going to lose all our benefits?
Our
Pension and everything, and what can we do, because some of these people have been there for so long and have worked with our youth to our seniors, and so they've built that trust in the community. Our Pueblo there, about 80% of the tribal members still speak the native language. So when we say 80%, yeah. And so when we talk about delivering culturally competent healthcare, then our own personnel, our own healthcare providers, they also need to converse in our language. Right now, how we're doing that is we utilize like the CHRs to go out and with the public health nurses, and they translate, back and forth. And Mr. Senator Tester had asked a question about prevention. And what we're doing, what we've developed there at the Pueblo, is to engage the youth and the seniors. How do you prevent these health disparities when the youth are actively engaging with our seniors, and they talk about growing up in the Pueblo, at the time when these changes were occurring from we're an agricultural society, and historically we've been farmers. What happened, and when we got the fast food industry, the sodas and all that, and a lot of us that were raised on that, where our seniors were at the tail end of them still consuming a corn-based diet, with also lean meats and whatnot. And so, that's important. And then we talk about food sovereignty also.
Right.
Reclaiming, what we produce.
I just want to mention a report that was handed to me over the weekend. The Shakopee contracted, I don't know if you've seen it, they've contracted for a report on how we can make the Farm Bill more responsive to exactly the concerns that you're raising. It's a pretty lengthy report. I haven't had a chance to go through all of it, but I want you to know I will be sharing it with my colleagues on the Ag Committee, because again, we can't silo this. I want to make a point maybe before Ashley talks, which is you come here, you incur all the expense, you sit at this table, you tell us this, but sometimes I'm sure you feel like what happens in this room stays in this room. It's kind of like Las Vegas, right? What happens in the Indian Affairs room stays in the Indian Affairs room. We're going to go to the floor today and raise these issues. We're going to try and elevate and amplify what you're telling us today. So it's not without, we're serious about this, I think, is what we want you to understand, that this is not the end all and be all, that this will go out of this room.
And that's what we're concerned about.
Yeah.
Lip service.
Right.
Staying here is going to be action, or at least helping us.
Yeah.
What we're saying is that lip service. We don't want to come here and tell you this stuff, but that it stays here. No, we want this to go out, some of this to go out.
Yeah.
To be able to express what we're all experiencing within our areas.
I just wanted to make one comment here. The special diabetes program for Indians has really helped and has worked in our community on I'm sure with many of the tribes. And unfortunately, it's going away, and I wish more funding could be put into this program. Again, it's benefited us greatly, and kudos to the MB3 Foundation, because they're out there advocating for our youth also. We work with them quite a bit with Noto Bigay. Thank you.
Ashley, you get the final word here.
Okay. So thank you for this opportunity. I wanted to start off with talking about the question of prevention. I think it was mentioned earlier that we really can't afford to not do prevention. That's where a lot of our efforts have to go to because of the funding level that we have. We have a motto in Detroit at our clinic that culture is prevention. And culture is a big part of that, especially when you look at mental health and substance abuse services that we provide. And I think it was asked how we can improve those efforts for prevention and culture within, the ACA as it is now, or in Medicaid. I know the state of Arizona has been working on an 1115 waiver to cover traditional services so that they become billable. I'm really close to the border of Canada, and we do a lot of work and go over to study how the clinics and the tribes are operating these services in Canada. And they're able to get funding for their traditional services. And that's a big piece of what's missing, I think, here on the United States side. As far as some of the prevention services, we're really big on fruit and vegetables. We prescribe fruits and vegetables to our clients. We provide them monthly boxes of fruits and vegetables because there is such a lack of access to grocery stores. We in Detroit, we suffer from some of the same issues that some of the rural areas have. About 3 years ago, we finally got our first grocery store, and it was a Whole Foods, which is not really affordable for most people. So the other thing we're fortunate to, this year we actually took over a 3-acre garden and farm and orchard. So we're actually part of that process of bringing that food to our community. One of the other things that I wanted to talk about, I know it was, there's a little bit of a discussion on some of the leadership issues within IHS. I think part of that and part of the stalling that we have in making any efforts is we don't have leadership. Since 2015, we have had 5 different directors. Name one for-profit company that would survive with 5 different CEOs in that short of a time span. We can't move forward. A perfect example of that right now in terms of what the Urbans have been doing in terms of working with the IHS director, we've been very fortunate to have budget increases for the last 3 years. It is currently the middle of July. I do not know how much money I'm going to receive from that increase, and I will have until the end of September to spend it. I will be lucky to get that 2 weeks before the end of the fiscal year. So I cannot plan even within a 1-year period. So while the VA has the 2-year, and we were talking about needing us having a plan year to year, at this point, I'm gonna be planning in weeks for something that is not sustainable. And that's a really big issue for us. I think the other, they talked a lot about the navigator training. I think that's crucial. We were very fortunate that we had a CMS navigator grant. I was actually a navigator. I was navigator by day, CEO by night, and really got that opportunity to meet one-on-one with these patients and see people in tears of joy of getting coverage for things that they have not been able to get coverage. And so firsthand, I've really seen that impact not just on my bottom line, but on that person-to-person connection. I think one of the big issues for us too, as Urbans, and I know I've testified about this too, is we're really concerned about the 100% FMAP for Urbans. We're concerned that some of the changes that have come out in the bills in terms of Medicaid cuts and other things that some of the tribes may end up getting protected from, that we're going to get left out of because we're not a part of that process. And so that's a really, in terms of what's kind of out there right now, another big issue for us. So thank you.
Thank you, Ashley, and thank you for all those comments. You can kind of see this coalescing. Before I turn it over to the Vice Chairman, I'm gonna just tell a story. I was invited to sit on a panel at the Youth Summit. President Obama brought so many tribal youth together, and these are traditional kids who very, very respectful. I mean, incredibly, culturally grounded, some of the best and brightest, and it makes you hope greatly for Indian country. And at the end, Sylvia Burwell, who was on the panel with me, said, I really want to work with the youth of Indian country. And she said, like for instance, I run Indian Health. The room exploded. I mean, these very culturally sensitive, respectful children. One person goes, that's the place where you go to sit and wait to die before you get health care. Literally shouted it out at her. And I think that it's unfortunate that it's unfortunate any of this happened, but it's unfortunate that I think the past administration came to the awareness that this is a system that is failing greatly in too short of a time to really begin these dialogues. And so I don't fault the administration, but I will fault us if we don't continue the work that was started. And so that's why we're here to talk about that we need a different result. You guys have come up with great ideas. I think we've got to figure out how do we build kind of a broader coalition of great ideas to do what's been suggested here, which is to look at an overall revamping of Indian health and what would that look like, rather than just patch it together. And the one thing, and you saw it when Senator Tester used that great temper of his in exactly the right situation, you saw what the frustration was. that it's not enough to have competent professionals at Indian Health. We need to have advocates. And that's been a problem all along. And it's not, that's a bipartisan problem. That is not new to this administration. And you know, I don't know why anyone wants a job heading up Indian Health if they aren't going to be that advocate, if they aren't going to scream from the rooftops. And we aren't going to confirm anyone to that position without a sense that they will go up against, you know, be the strongest fighter for healthcare in Indian country, not just maintenance, but fighting and advocating. So you have our commitment on that. And with that, Mr. Chairman, thank you for, Mr. Vice Chairman, thank you for pulling this together. And I look forward to continuing to work with you. And just a final note, one of the things that Tom did before the end of the last administration is he brought Mary Wakefield in, and we got a debrief from her. I think that we've got a lot of opportunity to build on some of that work, which you guys participated in, but take it to the next level. Yeah.
Heidi, thank you so much. She is a great champion for tribes and Native nations all across the country, and I really appreciate you stepping in and helping us keep this going and make a full and complete record, which is what we've done today. And I just want to thank all of you for spending the time, traveling so far, the expense and all of that. This has been a very, very constructive dialogue and discussion. And I want to repeat in a way, in just a little bit different way, what Heidi said about your voice is not staying in the room. I mean, I believe you're really making a difference being here. And it's like, in a way, you know, you have Bobby Kennedy talked about a pebble dropping in the lake, and it first starts as a ripple, and then it builds into a wave, and then it builds into a tidal wave to wipe out this ignorance and resistance to giving you a full health care system. And that's what your voices are doing, and they resonate today throughout the Capitol. I'm leaving here. I'm going to have a press conference statewide with all of my New Mexico people, and we're focusing on what you said here today. And then, as Heidi said, we're going to the floor this afternoon. A number of senators on the Senate Indian Affairs Committee that really care about tribes, and we're going to make the case once again. So we're going to fight tooth and nail, and we're not going to let them roll back that progress we've made, and we need, as you know, to make a lot more progress. Thank you very much, and at this point, I don't know if we say the hearing's adjourned or whatever. It's around.
Oh, what time is are you guys
please
scheduled?
go ahead, Wayne.
No, just what time are you scheduled to go on the Senate floor? And how do we get on there? I've
Yeah,
never
we
been
can
to the
get you
Senate
on
floor
there.
before.
We can get you in the gallery.
And the gallery, so it's 3:25.
325, yeah.
So if you're still in town, maybe someone from the committee can get you all badged up, so they'll take you over to our members gallery, you know, which will be easier, because a lot of times if our people go to the regular gallery, they can't really see us. So being across the way is important.
It's better.
So you're all invited to hear the comments, but I think to continue this discussion and this dialogue. Thanks, Wayne.
Thank you.
Thank you.
Thank you.
Thank you.
Heidi, do you want to?
No, I don't. Those are yours.